Okay, so we will read about cardiology chapter today and we will go in little fast manner because this chapter is little longer. Okay, it will take time. There are many concepts, so hold on with me and keep going. Okay, so first thing first, heart rate. Heart rate means chronotropy always. When we say heart rate, it means chronotropy. Okay, the SNOD, it is a pacemaker, work is pacemaker. The restless membrane potential of pacemaker is -6 to -40 millivolt. Okay, is if it is the SNO graph, why it is called restless? Because the resting membrane potential fluctuate -40 to -60. It is not fixed like nerve -90 millivolt. Okay, in this we have phase 4, 0, 3, again phase 4. This is phase 4. It is a pre-potential phase. Pre-potential phase due to calcium influx by T calcium channel, sodium funny current, and decrease in potassium efflux. There are three causes of prepotential phase. Main causes calcium influx by T calcium channel and sodium funny current. Harrison book is mentioned in the prepotential phase. A phase 4 result from funny channel along with T and L both type of channel. Okay, remember this if they confuse you. Okay, so phase 4 is by T and L type channel, sodium funny current, IF channel, and decrease in potassium influx. It is 0. It is the this phase is phase 0. It is the depolarization. Depolarization in SNO is occurred by calcium influx by L type, long lasting type calcium channel, and repolarization occurs by potassium efflux. Potassium is going outwards. Mean potassium going outward mean inside it is making of negative charge again. It is what is sodium influx funny current or IF channel. It is the SCN channel, also known as hyperpolarization cyclic nucleotide channel. Nucleotide sodium channel, it is also present in eye. The blocker of IF channel is known as ivabradine, and the side effect of this drug is visual decrease in visual acuity. The SA node is normal heart rate is 72. Actually, its normal heart rate is 100, around 100, but due to firing rate is 100, but due to resting vagal tone means parasympathetic activity, the heart rate is little below to the normal around 72. It is PYQ. A heart rate starts from SA node to AV node beating. AV node is physiological conduction delay. Delay by 0.10 second का 0.10 second का delay होता है, followed by His bundle, highest conduction velocity, highest gap junction, and Purkinje fiber. Next, what is gap junction? Gap junction, you know from further classes या behind classes, gap junction is a type of junction, different type of junction present between the cells. It is one of the junction, gap junction. It it is the uh, control. It is not the control of ventricular myocardial cell at the same time. Okay, coordination of ventricular myocardial cell at the same time. It is a contraction of ventricular myocardial cell at the same time contraction करने में help करता है. Also known as, this is known as synchronized contraction or functional syncytium. This condition of ventricular myocardial cell is known as functional syncytium. It is made of connections and histopath found in intercalated disc. Okay, this what sympathetic nervous system do, it increases the heart rate. Okay, so this means it occur fast, mean the slope is increases. Okay, in parasympathetic nervous system it decreases the heart rate, means it decreases the slope, means decrease slope of pre-potential phase, means it take more time, it heart rate becomes slow. Okay, in ventricular action potential there is four phase. Zero start by 0, 1, 2, 3 and 4. Okay, in one known as early depolarization due to sodium influx. In the SA node, the depolarization is due to calcium influx. Remember this. Early depolarization by calcium influx. Plateau. Plateau is due to calcium is also inside via L-type calcium channel. Potassium also going outward means plateau. Both are doing equal. Both are working is equal. So the plateau up, not down. Third, this is the late depression phase due to calcium efflux, more calcium efflux. And phase 4 is the maintenance RMP by sodium, potassium, ATPase. Okay. Here it is the automaticity found. Automaticity found. Why? Or reason of automaticity is these three channels, L-type calcium channel. But the main cause of automaticity is sodium funny current. Okay. There is no automaticity here. In the ECG, we have three type of lead: limb lead, augmented leads, and chest leads. V1, V2, V3. These are the chest leads. Augmented lead are three: AVR, AVF, AVL, and 3 limb leads. Enthomin made the triangle by the which leads? Limb leads. Okay. Lead 1, 3. You know vector 1, 3, and this vector is opposite. So 1 plus 3 is equal to 2. Okay. Remember this, they will give you 3 and 2 and ask what is the third. This is the placement of leads. This is one plane, remember, and this red is different plane. Red is going in front of your chest. Okay, so from V1, V2, V3, V4, these are the chest leads in front of you, occurring from you in front side, and these are the chest lead in the same plane. Okay, these are the chest lead. So inferior leads is third, AVF, and second. These are the inferior leads RCA supplied by RCA. These V1 to V4, these V1 to V4, while in front side it is septal or anterior surface leads. It is the most common lead that is affected in LED, left anterior descending artery infection, and the V5, V5, V6, first, and AVL. These leads are the lateral leads affected in lateral ischemia. Okay, this is, if you say this is the ECG, if you say closely, there are 25 blocks, 25 small square, and in the height ratio, one small square is equal to 0.1 mm, means 5 means 5 millivolt. In the height area, in the y-axis, we will take voltage. In the x-axis, we will take second. One is equal to 0.04 second, means for one full block, it is 0.20 second. Okay. This is ECG. This is P wave, P followed by QRS, followed by T wave, followed by U wave. Okay, this is QRS, this is PR segment. Always remember segment being single. You can remember this mnemonic. Segment with single means there is no wave, there is no upward or downward movement is included in the segment. Segment means single. Okay, in the PR segment and in the ST segment, though no upward or downward movement is included. This is J moment, J point. In the PR interval, we will see P wave. In the QRS, QT interval, we will see QRS and T upward movement. Okay. Okay. In the QT interval, this is QT interval. It is the total ventricular activity. QT interval means total. It is a QRS, ventricle depolarization, ventricular repolarization means total ventricular activity. It is normally 0.40 second. Corrected QT interval means QT interval divided by RR. Corrected why? Because in many of the patients the difference between the multiple RR leads are not equal. This formula is known as Paget's formula. J point, there is no current for normally, but in the ischemic patient or in the ST elevation MI, you can see the elevation in the J point. What the P wave lead to? It is the atrial depolarization. QRS is ventricular depolarization. T wave is ventricular repolarization, and U is the late repolarization. Okay. What depolarization? Depolarization occurs in the left to right. Left to right means SA node to AV node. Two side means left to right. It is from septum to endocardium to epicardium. Septum to endocardium to epicardium depolarization, and repolarization occur in right to left means epicardium to endocardium to septum, means epicardium to endocardium to septum. Okay, PR interval is P wave plus AV delay. Okay, P wave 0. Total is 0.20 seconds, means almost 5 small square. Prolonged P wave is more than 0.20 second in cardiac. It is seen in cardiac conduction defect. RR interval, it is equal to heart rate. In the small square, if we take, we will take 1500 divided by square or 300 divided by large square. Okay, you can do it. This is all about our heart. S1, second S2. In the S3 and S4, S3 and S4 come between the, it is a diastolic phase. Okay, cool. It is a systole, it is diastole, complete. We will talking about ventricular systole, and we will relation here ventricular diastole. Okay, so this is lead. If someone is saying what is the direction, deviation, right axis deviation, left axis deviation, we have to see two things, lead 1 and lead AVF. First, these things. This is known as positive because in QRS this is positive, this is equiphasic, you can see, and this is negative. Okay, It is normal axis because all this is plus. Okay, normal. In right axis deviation, if the you can see in this graph, in normal range, in this normal range, this is, but in left we have two things, normal also and left axis division also. So if anything comes in this zone, we have to differentiate either this is LED or either this is normal condition. So we have to take in the further LED. If there is left axis deviation, we have to see lead to also. If lead, if positive, it is normal. If lead second is also negative, we will see it is a LED, left axis deviation. Okay, in this right axis deviation, in this, see, you can see it is negative and this is more of positive. This is first is negative, like you can replace it here. First is negative and AVF is positive, mean somewhere here. Okay, so it is right axis deviation for this question. Okay, I can see that it is very easy. His bundle diagram, his bundle ECG. This is A, this is H, this is V. Nothing specific. Just after atrial depletion, this is the AV node. Okay, so this is P wave of ECG followed by this is AV bundle. Also atrial bundle. This is his bundle ECG and this is followed by ventricle. So this is the PA interval. This is AH interval. मतलब AV node conduction from AV node to his bundle. Okay, and this is from conduction of his bundle to ventricular. It is the ventricular depolarization started here. Easy. This is the internal jugular vein. This is JVP. JVP is dead. We can measure the JVP in internal jugular vein. Internal jugular vein because it is more straight, easily accessible, easily visible actually. The PYQs, mostly PYQ, mostly examiner asks about the C wave. What is C wave? Isovolumetric contraction of right ventricle. This is actually, we are talking about the right atria, and in the right atria we are seeing only right, what happening in the right atrium only. So in the A wave, it is the right atrial contraction followed by relaxation followed by right ventricular contraction. Why this C wave is here happening? If right ventricular, if right ventricular contraction, it the this is bulging. What is bulging here? Isovolume contraction of right ventricle. What is bulging? Tricuspid valve is bulging. If the tricuspid valve is bulging, it will lead to sudden tip, sudden upstroke. That's why it is the seeing the C wave is as upstroke, not as much strong as atrial contraction is doing it. But we will see, we are seeing it is little spike. So this is showing right ventricular contraction followed by passive atrial filling. Means it is the atria is filling passively. Okay, followed by this wave, maximum atrial filling because heart is coming back, and now this tricuspid valve is opening. After the tricuspid valve is opening, the pressure is drop again and atrial emptying is done. Okay, uh, the question asked one time that A wave is preceded by P wave. Actually, atrial contraction, P wave occurring just before it, before the atrial contraction. This question is multiple time asked. What is the right ventricular contraction denoted by C wave in the JVP? Okay, I hope you understand this graph and all. So we will discuss about now cardiac cycle. Okay, the cardiac cycle is total of 0.8 second and it is divided more on heart rate. Okay, simple is atrial systole is 0.1 second and atrial diastole is 0.1 second. Same in the ventricular systole is 0.3 second and ventricular diastole is 0.5 second. Okay, if we do exercise, cardiac cycle minimum. If we do exercise, means your heart rate is increasing. Means cardiac cycle become small. Means it become only for 0.3 second. The ventricular systole decreases to 0.12 second, but ventricular diastole becomes 0.8 seconds. 0.3 to 0.12 is almost 4 times divided, but 0.5 to 0.18 is much more divided. Means what is compromising? We are compromising ventricular filling is compromising. Means less fluid is filling, less blood is filling in the ventricles. Okay, so in the if we are relating what ventricle systole, there is it is 0.3 second. We have three phases. Isovolumetric contraction. Isovolumetric contraction means heart is starting to contract. Okay, means it is the closing of which wall? Mitral wall. Okay, or tricuspid wall we can say. It lead to S1 because this is isovolumetric. There is no volume change. There is no valve is open, but mitral valve is closed and denoted by S1. The pressure is increasing. Okay, it is a closed box. If pressure is the pressure is increases, contraction increases, the pressure increases, and pressure means because the closed box is try to open, so the pressure is increases, and in the end of isovolumetric contraction, what is opening? Aortic valve is opening. After the just like aortic valve opening, we are doing rapid ejection by the two-third. Second phase is rapid ejection two-third, and slow ejection phase is 1/3. What is left? After the ventricular systole is finished, it is the systolic and systolic volume around 50 ml is left. Okay. Ventricular diastole. Ventricular diastole means it is the phase of filling. Just after slow injection phase is finished, we are closing the aortic wall. It is known as protodiastole. Protodiastole means closing of aortic wall. This a sound is produced also known as S2 sound. Okay. After that, everything is closed for the ventricle. This is isovolumetric relaxation. Easily means volume is same, but the pressure is falling. After that, there is rapid filling phase. It is the passive filling phase just because tricuspid wall is opening now, and all the blood that is filled till now is rapidly ejection into the 80% filling is the continuous filling, rapidly ejected into the ventricle. But later, atrial is filling slowly filling. It is known as diastasis phase, slow filling phase, 80%. In the rest phase, what is the left in the atrial? It is actively filling by atrial kick, also known as atrial contraction, and the 20% filling is done by this. 80% is done by two phases, rapidly filling, 80% by rapidly filling and slow filling diastasis phase. That rest 20% is filling by the atrial kick. Okay. So if you can see by this diagram that 50 ml is ESV and systolic volume. After that, ventricle started filling. Okay, ventricle started filling and mitral valve is closed now. Mitral valve is closed when which step is initiated? Ventricular systole is stated means isovolumetric contraction. Which valve is open after isovolumetric contraction? Aortic valve. I told you which valve is open here? Aortic valve. As I told you, after aortic valve is open, rapid ejection phase of two-third, followed by slow ejection phase of one-third, followed by closure of which valve? Aortic valve. After closure of aortic valve, it is a protodiastole. After we have isovolumetric relaxation, and the mitral valve is open and rapid filling, slow filling, atrial kick, all is done in this phase, ventricular filling. Okay, so I hope you understand this diagram. So S1 is the closure of mitral valve denoted by R wave. Okay, P Q R, this R wave. It is the closure of mitral valve. Okay, closure of mitral valve or tricuspid valve. It is the starting of main phase. Ventricular systole is starting its main part. S2 is closure of atrial, closure of aortic valve or pulmonary valve. It is the end of T wave. It is the actually end of T wave. End of T wave means after the full after almost replication starting finished. Okay, third phase of diastole, which is rapid filling phase. Okay, child in an exercise patient, it is the rapid filling phase, and we are telling about vibration. Actually, it is the vibration that is we are feeling in the S3 phase. Okay, actually, in the keyword they use the vibration word, so they are almost talking about the S3 phase, and it is a rapid filling in the cardiac cycle. It is normal, it is physiological also in child and exercise, and it is pathological also. Okay, but the S4 is always pathological. What is actually S4? If this atrial kick is almost 20% filling, if in the atrial kicking heart is atria is giving more pressure, means if the ventricle is stiff, atria have to push very hard in the like restrictive cardiomyopathy or long-standing hypertension. Atria have to push very hard, and this wave S4 just before the P wave. Okay, just before the P wave S4 is occurring, and we mentioned to before P wave. Okay, before P wave is occurring, and there is no keyword. They never use keyword here vibration because it is a kick. It is the hard kick. Vibration occurring in S3 phase. Okay. There are some terminology used. Some question is what is LVT? It is a from carotid artery pressure rises to closure of aortic wall. Actually, aortic wall closure, carotid artery pressure, as carotid artery pressure is rising just before the in the ventricular systole phase, and closure of aortic wall. Okay, closure of aortic wall means VD. It is the time of LVET, and QS2 between QRS complex in the ECG to closure of aortic wall S2. This is the there are some formula of pre-ejection phase. Pre-ejection phase QS2 time minus LVET. If you think hard, you will see it is the pre-ejection period, and stroke volume is stroke volume. What is stroke volume? What we did. And diastolic volume 120 ml, we have this much fluid, and we left with 20 ml, and systolic after systole. So what is this stroke volume? What is stroke volume? After end diastolic volume, in the end systolic volume, if we see, there is change around 70 ml. Okay, so this 70 ml is stroke volume. Ejection fraction we can calculate by stroke volume after and diastolic volume. Okay, and diastolic volume, because we 70 ml 1 upon 120 ml into 100. If we calculate, it is around 55 to 60%. Okay, remember it is the end diastolic volume. It is the higher side, higher from this. Okay, cool. Just like chronotropic, what is chronotropism? Chronotropism all about heart rate, but inotropism all about contraction. It is a ejection fraction. Okay, contraction. So cardiac output is 5 liter per minute. Cardiac output is heart rate upon stroke volume. Heart rate into cross stroke volume. Stroke volume dependent. What is the contract of ventricle? What is preload and what is afterload? Okay. In the preload part, volume of blood in the left ventricular after diastole. Okay. What is left in left ventricular after diastole? It is the end diastolic volume. Depend on this. If the end diastolic volume is more, you have more preload. It is the volume based parameter. Okay. What is afterload? Afterload is pressure dependent. Okay, and diastolic volume is pumped by the ventricle into the aorta against aortic pressure. The pressure in the aorta, total peripheral resistance, it is defined by this. So afterload will be less if the cardiac output is more. Afterload will be less. Okay, because we are easy to push. Okay, heart rate and kidney is a two parallel system. If one kidney is damaged, total peripheral resistance is, because in the parallel we have different formula for resistance, and if parallel is removed by this, resistance is increased. So in parallel, if we remove this, total peripheral resistance will be increased and cardiac output will be decreased. It is the pressure based. Okay, so afterload is more of pressure based, but the preload is more of volume based thing. The fixed principle for the cardiac output is equal to amount of oxygen consumed upon arterial minus venous pressure oxygen. Other method to for cardiac output are thermodilation and echo. To the echo, they are asked this: if what are the which of the following is not a method of measuring of cardiac output? Fixed principle, thermoregular dilution, and echo. These are the three methods for the measure of cardiac output, measuring of cardiac output. Okay, there are some things you have to rectify this. I can't do anything. But the highest blood flow in the liver, it is the highest oxygen consumption liver do per 100 gram of tissue. In highest is the kidney, and lowest is the resting skeletal. Highest blood flow, lowest blood flow for 100 gram of tissue for highest is the for kidney, lowest for the resting skeletal muscle. CIR is the cardiac index ratio is 3.2 liter per minute per meter cube. Area most susceptible to ischemia is the subendocardial region. Okay, just like in the S3, in the kidney, it is the S3 phase of PCT. In the heart, it is the subendocardial region. In the per 100 gram, highest oxygen consumption occurred by the heart, and highest oxygen extraction is also occurred by heart. But the least AV difference or least oxygen extraction is by the kidney. It is the PYQ that is asked. Okay, that's why I included these tough things. Okay, the coronary blood flow now play a very minor role in the coronary blood flow, but the local factors plays important role, and these are the major role is the by the adenosine, very important, NOH plus, and local products of metabolism, something like that. What is the positive relation is a very conceptual thing. What will do if we stand the decrease blood pressure decrease and it is back to normal because of baroreflex. We will read baroreflex later, but why the pressure decreases? It is a venous pulling in the lower part of the body. So if the venous pulling is in the lower part of the body, we have decreased venous return. If the venous return decrease, the cardiac output also decrease, but the total peripheral resistance increase because we have to contract more hardly because blood is already there. Cardiac venous central venous pressure is also decreased because we are unable to contract due to less cardiac output, and heart rate to compensate it is increasing. Okay, to men we can remember this by like this. Hypo, it is a concept. The concept is also same like this. Hypovolemic shock. If you are unable to remember or understand some concept, I have to go fast, else it will become 2-3 hours. The lecture will become 4 of 2-3 hours. Hypovolemic shock stages. There are three stages. Non-progressive stages. It is due to increase in antidiuretic hormone. It is sympathetic stimulation by noradrenaline, increase in heart rate, cardiac output, BP. We are saving the patient. We want to kidney want that we will get something in the kidney, constriction of afferent arteriole and direct blood to vital organ, because kidney is not at vital. So in the kidney, we are we are doing constriction of afferent arteriole, leading to direct blood to vital. We are getting more blood in the vital organs. Okay, in the progressive, if the hypotension is still progressive, someone is still losing the blood, it will lead to decreased coronary blood flow. Means we have to start positive feedback. In this phase, positive feedback started means further cause cardiac deterioration, and in the if we go in the irreversible phase, it is the loss of energy source and the patient will succumbs. Now this is the easy part we are talking about. In the intrauterine part, from the 3 week to 3 month, the yolk sac is responsible for the formation of blood. Okay, RBC. In the intermediate part, from 3 month to 5 month, the liver is plays in the main role, and the 6 month, 3 month of intermediate to 5 month, and 6 month to 20 years of age, the red bone marrow of long and flat bones is the important thing. And after 20 years of age, the red bone marrow of flat bones is the very important. Sternum is very important. In the simple, we can say the pluripotent hematopoietic stem cell, the transcription factor released from their GATA and efferent of GATA that do that release burst forming unit for erythrocyte and followed by colony forming unit of erythrocyte made up followed by proerythroblast, basophilic erythroblast, polychromatic erythroblast, orthochromatic erythroblast, reticulocyte, erythrocyte. Okay, you can remember the earliest committed progenitor that lead to erythrocyte burst forming unit erythrocyte. We are coming with erythrocyte name and the highest erythropoietic receptor in the colony forming unit. Okay, you can remember in the colony we have receptor, colony of receptor. This is the colony of receptor. So we have highest erythropoietic receptor. The hemoglobin pro means we are something we have defined this. So it is the proerythroblast means the hemoglobin synthesis maximum in this started from here proerythroblast, but where it is seen where the color is changes, where the chromatic appearance multiple chromatic. This is the hemoglobin appear first, and the complete hemoglobin present in ortho. Okay, just like orthopedic is complete doctor, almost you can remember like this. In orthopedic complete doctor, it is the complete hemoglobin present in orthochromatic erythroblast. Okay, uh, highest erythropoietic receptor did which hormone act here? Erythropoietin hormone. Three main thing: kidney, eye cell, it secrete 80% of responsive for the erythropoietin, liver and brain. In the brain or in these all things, we release hypoxic inducible factor. By this erythropoietin is secreted and it act by JAK2 state pathway, JAK2 state pathway. Okay, if we see normal oxygen or normal partial pressure oxygen, HIF in the sick, hypoxia inducible factor plus von Hippel factor work, and there is no HIF free, so no erythropoietin synthesis. But if PUT decrease, the HIF hypoxia is separated from the VHL and erythropoietin synthesis increase. What is the recombinant erythropoietin that we are using is apoietin alpha and darbepoetin alpha. So increase in erythropoietin is done by erythropoietin, increase in RBC is done by erythropoietin, growth hormone and T3. Cortisol, testosterone. Testosterone also is that's why male have more number of RBC. Okay. This is this is something WBC. WBC have two type granulocyte, agranulocyte for the neutrophil, eosinophil, basophil, monocyte. Okay, this monocyte also. Okay, they develop from GMCFU. Lymphocyte is developed from different lineage. For the drug of GCSF, GCFS and GMCS, nothing is specific. Like GMCFU is only neutrophil using basophil and GCSF only producing lymphocyte. Nothing is like that. They both are producing neutrophil using of neutrophil and monocyte. There's something little bit difference. In the drug GCSF, it is the filgrastim, and GMCSF is the sargamostim. More M, more, है ना? More M. Sarga M for M. Never suggest these type of tricks, but you have to remember it. GMCFF Sargar Mostem. For the thrombopoietin, the drug is L-trombopag. Okay, there are some interleukin that also stimulate the formation of WBC, just like interleukin 5. Remember, ask PYQ, eosinophil. Interleukin 3 and 4 for the basophil, and interleukin 11 thrombopoiesis. Okay, for interleukin 11, we have leukin. You can remember by this. In the interleukin 11, you have this leukin. Okay, this 11. Okay, so what is interleukin 11 receptor? Drug that work on interleukin 11. It is a leukin, but the thrombopoietin drug is the L-trombopag. Okay, so there is Starling forces. You easily remember Starling forces. So I am not concentrating here. It is the partial. It is the hydrostatic pressure of the capillaries. It is the outward. It is forcing blood or any fluid to go outward. It is the net filtration pressure. Okay, so it is the it is the hydrostatic pressure of capillaries, and it is the oncotic pressure of interstitium. Okay, this is that is pulling interstitium, that is pulling. It is a 3 mm around, and in minus oncotic pressure of capillaries, that is pulling back. Okay, or hydrostatic pressure of interstitium, that is also pushing. Okay, in the capillaries. So it is actually filtration. We in the filtration we have to push out something. Okay, so what is helping? Hydrostatic pressure of capillaries, and what is pulling it? Oncotic pressure of interstitium. Okay, these two forces are pushing. These needs more blood in the filtration capacity. Okay, so this is the Stalin forces, and you have to remember it. Anyhow, next, this is very easy thing. By the heart, we started by heart, and then the blood goes out. It is depend all about cross sectional area. So blood velocity depend on cross sectional area. So in the aorta, it is the highest blood flow. It is the have lowest cross sectional area because it have elastic recoil. It is responsible for diastolic blood flow. Okay, it is responsible for diastole. In the elasticity, because it have elastic recoil, it have elasticity property. These vessels for this cause is also known as Wind Kessel. Wind Kessel artery, or we are showing this effect. Elasticity effect is also known as Wind Kessel effect. We have to the blood pressure remains around 120 to 80. In this protein that are responsible here is elastin and fibrillin. Main is elastin. If we have elastin mutation in the present as supravalvular stenosis, diagnosed disease as Williams syndrome. And if we have mutation in the fibrillin, we have fine dilatation of aortic root, and this is very famous disease, Marfan syndrome. After the aorta, we have arteries, okay, conducting arteries, and we have then arterioles. In the arterioles, we have smooth muscle. Only here we have smooth muscle. In the if we have smooth muscle contraction, it decrease blood flow. Example, Na is noradrenaline is main thing that is work here. In the relaxation, we have increased blood flow. NO function is called arterioles is called resistance vessel because we have smooth muscles and that produce resistance, means it will help in regulation of blood flow. In the arterioles and in the capillaries, we have precapillary sphincter. This sphincter do the intermittent contraction and relaxation, contraction, relaxation. This is known as precapillary sphincter. This motion is known as vasomotion. Okay. In capillaries, also known as extens vessel, it is largest cross sectional area. Largest cross sectional area means minimum velocity. Total 5% of total blood flow. It is the lowest blood flow. Veins, what is veins? Veins is known as in this between, if no capillary is present in some part of body, there is no capillary is present, it is known as arteriovenous stenosis, direct connection. Okay, it is seen in skin, fingertip, earlobe, also known as shunt vessel, AVN stone, also known as shunt vessel, if there is no capillaries. In the veins, if we see, veins also known as capacitance vessel, they are the storage reserve, and because veins have least pressure, the volume is more, means maximum storage. 55% of blood is stored in the veins only. If we see this stalling force, we will continue it here. The lymph edema form because either we have decrease albumin. If we decrease albumin in the interstitium, okay, more filtration pressure will be decrease. Means We have live in the liver disease, the decreased production or decrease in the kidney disease, more excretion. Nephrotic syndrome means more lymph, more edema is formed. Okay, because in the capillaries, it pull pull the blood in the capillaries, and if we PC have less, more blood will remain here. Okay, in the outer side of capillary. So in the PC, we will see the PC long standing hypertension, lymphatic obstruction. These are the cause of more edema formation, more lymph formation, lymphatic obstruction by the microglia. Okay, so th this is done. We have famous formula, Poiseuille-Hagen law of blood flow. This is something we have to remember. PYQ is asked. Blood flow dependent on pressure in the two things, PA minus PB, pressure here minus pressure here. Also followed by also directly proportional to radius R4 to the power 4. It is the most important factor among all, divided by the viscosity. So pressure changes is equal to blood flow into R. Okay, blood flow into done. Okay, upon viscosity or also inversely proportional to viscosity, inversely proportional to length. Okay, remember this. Okay, it is the R means resistance. Pressure is the blood flow into resistance. Okay, resistance divide is proportional to inversely proportional to R ki power 4. Velocity depend upon 1 upon cross section area or 1 upon area or 1 upon pi R square. So velocity depend on R square, but blood flow is depend on R to the power 4 and it is directionally proportional. Okay. So plus pulse pressure is systolic blood pressure minus diastolic blood pressure, or mean arterial pressure is diastolic blood pressure plus 1 by 3 of pulse pressure, or systolic blood pressure plus 2 by 3 of diastolic blood pressure. Remember both the formula. There is some data. Pulmonary capillary rate pressure is 4 to 11 mm Hg, 12 mm Hg, average 10 mm Hg. This is the pressure in uh, different chamber of the heart, right atrium, right ventricular, left atrium, left ventricular in the systolic phase, and in the diastolic phase 0, 5, 4, 4, right atrium, right ventricle, left atrium, left ventricular. Okay, this is something important. We have two pays, three pays, four pays left, but this is something very, very important. If you are, okay, so in the BP measurement, we have two things. Direct BP measurement in animal due to research. We have to put intra-arterial, we have to put a something catheter or sensor, and we have to measure the BP. It is of high value. It is give exact value or high value from the normal value, because we are overestimating, overachieving something. In the indirect part, it is the most common use. We use sphygmomanometer, and it underestimate BP by systolic blood pressure, because of there are in the artery, we have muscle, we have bone, we have many things that underestimate the BP. So the question is, what are the cases in which falsely high BP is measured? If the cuff is of small size, because if the cuff is small size, we have to make it very tight without inflation. It is without we when we bind it to the hand, it is more tight without inflation, lead to more rise in pressure. So the pressure is fastly high. In the obese pressure, it is fastly high, or the vessel are too thick, so it is too high. So what is the ideal cuff size? So it is, if we say it is the arm circumference, if this is arm circumference, though 80% of the bladder is 80% of arm circumference in the length, and 40% of the arm circ width of the this of the arm. We are not talking about cuff, we are talking the bladder that you are inflating, not complete cuff. Okay, this cuff is known as Riva or Rocky cuff. So this is something we have Kortikov sound, you know it. So just when we are raising the blood pressure from 80, we have 120, we have 180, 160 around, the artery is occluded, no flow is flowed, no blood flow is flowed, we have silence. After when we have around pressure around 120, we have systolic blood pressure around, we are seeing first sound, you know, you remember it, you saw already, it is the tapping sound, it is known as systolic blood flow, it is the audible turbulence. In this feed, those all five phases, when we have systolic blood flow to these four, we have all four. First tapping, then we have murmur like sound, then we have crisp sound and clear sound, we have muffled sound, and after in the phase 5 of this we have disappear sound is effaced, because the audible turbulence is minimum, because your जो inflation is completely open, there is no inflation left, means artery will flow, blood will flow uncompressed, and it will flow means it will cause no sound, means the diastolic pressure is, remember, off. If the diastolic pressure or the cortic of sound is absent, we have normal flow, silence. So this is the normal flow. This is known as silent pressure is due to it is the laminate blood flow is occurring. If we have still have noise, it is the turbulent flow. Okay, normally the turbulent flow is when the blood is very when the blood flow is very high, like in aorta, because it is more close to heart. In the pulmonary artery, we have almost turbulent blood flow. So laminar blood flow is determined by the Reynolds number, and it is depends on density of blood, diameter, velocity. Okay, so Reynolds number, it is a 1 upon velocity. Okay, so Reynolds number, if less than 2000, it is laminar blood flow. Okay, more than 3000, the turbulent blood flow. 2K to 3, 2K to 3T is transitional. In the anemia, we have decreased viscosity, means it will lead to more Reynolds number. Okay, mean more murmur. Okay, this is the cause in the anemia. It lead to decreased viscosity. In the decreased viscosity part, more Reynolds number and more murmur. Okay. The part we have left, it is a chemical control of BP. There are two control: vasoconstriction by the urotensin, that is most potent, rectify things, endothelin, ET1, the most small, ET1 to have, also to have ETA, ETB. ETA1 is more response. In the cause, in the lung, it causes PH, pulmonary arterial hypertension, because it vasoconstrict the thing, and the receptor blocker for this is bosentan. Vasopressin, we use talipressin for the vasoconstriction. It is used in esophageal varices. It is a vasopressin analog, and antithrombin third act on RAS. Okay, angiothrombin, act on RAS. What about the vasodilation? Vasodilation decrease BP by the CGRP, calcitonin, G receptor peptide, and you remember the full name. It is the most potent. NO, second messenger, CGMP. It is a PYQ, which second messenger used in for NO. It is a CGMP, and natriuretic peptide 3 type, ANP, BNP, CNP. For the analog of BNP, it is natriuretic, also PYQ, that is asked. Okay, we have something called clotting system here. We will first revise clotting system, and they will followed by blood pressure regulation. Okay, so platelet addition, it is by the GP1B is 9, and platelet aggregation by GP second B third A, second B third A, GP1B. First remember addition, first addition, second aggregation. Okay, then it is formation of primary hemostatic plaque and followed by definitive clot formation by the clotting factor. There are some main clotting factor: antihemophilic A for factor 7, B for factor 8, Stewart power factor, uh, antihemophilic factor, factor C in the PTA deficiency. Okay, intrinsic factor are 11, 12, 9, 8, extrinsic are third, 7. Common factor are in the pathway. Intrinsic pathway we have 11, 12, 9, 8. In the extrinsic we have third, 7. Common pathway 9. It is 10, 5 prothrombin, fibrinogen 13. Vitamin K dependent factor are 2, 7, 9, 10, and protein C and protein S also. It is a warfarin that inhibit gamma carboxylation, that inhibit vitamin K dependent factor 2, 7, 9, 10. Okay, PYQ. Warfarin act how? By the stopping gamma carboxylation of vitamin K dependent factor 2, 7, 9, 10. PT is external in the occur on the it affect the extrinsic pathway and is common pathway. So normally it is normal 11 to 16 second. Extrinsic pathway mainly for factor 7. For the APTT is the intrinsic pathway and common, it is 26 to 40 second. So normal BT blood, it is different. It is for the clotting factor. It is for the platelet bleeding time and clotting time 3.6 and 2 to 8 minutes. So anticoagulant pathway, thrombin plus thrombomodulin. What is thrombomodulin? It is present everywhere except cerebellum. In the cerebellum, not in the, no, it is not present in brain. So thrombin plus thrombomodulin plus lead to protein C and S activation, and it inactivate factor 5 and 8. Means protein C and 8 are the help in anticoagulation. Okay. These thrombin plus thrombomodulin also activate tissue plasminogen activator that activate plasminogen and that stop that formation of plasmin or fibrinogen. Okay, done. After that, we have the blood pressure. In the blood pressure part, we have short-term control by the baroreflex, chemoreflex, CNS, ischemic response. We have intermediate mechanisms like act within hours, like capillary fluid shift mechanism, stress relaxation, RAS, DAS, and long-term relation in days, like kidney pressure dialysis means if the blood pressure rises for the long term, kidney secrete more blood. More blood means kidney it release excess pressure by increasing urine output and means it regulate BP by regulating body fluid volume. Okay, so in the short term we have baroreflex, chemoreflex, we have chemical control of BP here. Okay, this is chemo reflex also, and we will start baroreflex. So blood pressure is the single most important factor for regulating blood flow. Okay, for the short term we have nervous control, but chemo we have local response for coronary blood flow, we have no nervous control. So for the short term, for the seconds we have baroreflex, it is a negative reflex or negative feedback means if the blood pressure is increasing, we will decrease the blood pressure. So what is the receptor? It is the carotid sinus or aortic sinus. What is the afferent? It is the ninth nerve by Herring's nerve and tenth nerve by Seance nerve. What is the center? It is the medulla. Medulla means which center? Nucleus tector solitarius. Output is sympathetic nervous system and parasympathetic nervous system. And response is inhibition of sympathetic nervous system because the increasing BP, we have to decrease BP. Stimulation of parasympathetic because in the baroreflex we have increasing parasympathetic nervous system means the both BP and heart rate is both will decrease. Don't remember like this that BP will decrease and heart rate is increase. We are wrong here. In the baroreflex, we have decreased BP and decreased heart rate both at the same time. So, uh, ninth and tenth nerve is also known as sinus nerve and buffer nerve. Okay, because arising from carotid sinus and aortic arch. So, ninth nerve is known as sinus nerve and tenth is buffer nerve because something is we are doing buffer in the blood, okay, controlling blood pressure. So in the carotid sinus and aortic sinus we have one nerve, glossopharyngeal nerve, and then we have another nerve by the aortic arch, vagus nerve, going in nucleus tector solitaris present, okay, present in the medulla part, and this is stimulating caudal part. Which part? Ventrolateral, caudal ventrolateral medulla, caudal ventrolateral medulla, ventral and lateral part of the medulla by the glutamate. Okay, this is important question. Which receptor? By the glutamate, and it is also inhibiting which thing? Rostral ventrolateral medulla by the GABA. Okay, this nucleus also is stimulating nucleus ambiguous because we are stimulating rostral medulla by so we are inhibiting all this system. Okay, and we are stimulating nucleus ambiguous part. We are stimulating nucleus ambiguous part means these parasympathetic nervous system will stimulate and it will lead to parasympathetic heart rate will decrease the deceleration, decrease heart rate, decrease blood pressure. Okay. If we go about sympathetic nervous system, the sympathetic nervous system is work in different manner. Okay. Cool. Uh, Cool. Okay. Normally, this is known blood. If the blood pressure is increasing, the heart rate will decrease. Okay. It is the reverse proportional to each other. This is known as Mary's law. There are some other baroreceptor also. This is known as atrial baroreceptor. They are the low pressure baroreceptor, also known as volume sensing receptor. There are two type activated during aortic atrial systole and active during atrial diastole. Okay. So PYQ extra for carotid sinus baroreceptor that it is present in adventitial layer of blood artery or blood artery. It is the high pressure receptor. Okay, ninth nerve is innervated and the pressure is the mechanoelectrical. Mechano means changes in pressure lead to electrical activity. Ion changes. It is a non-selective cations. Okay, so what we do if we occlude the common carotid artery? Okay, just imagine we occluded the common carotid artery. This something we are stimulating from here. Okay, if we occluded the common carotid artery, the blood flow to carotid sinuses decrease. Because blood flows to carotid sinus decrease, the barosinus will think that baroreceptor blood flow decrease, baroreceptor will inhibit, and sympathetic nervous system will stimulate due to blood pressure and heart rate will stimulate. But what if what if we clamp below the carotid sinus? Either occlude to CCA or occlude we can say clamp below the carotid sinus. Okay, the it means same for both. But what if something? someone clamp above carotid sinus here. Okay, if we clamp above the aortic sinus, pressure builds up here. The pressure builds up, but what will baroreceptor do? It will decrease. So baroreceptor will stimulate and it lead to decreased blood pressure and heart rate. Okay, in the PSVT part, we do carotid sinus massage and the heart rate will decrease. Okay, because baroreceptor will decrease, stimulate parasympathetic and decrease the blood pressure and heart rate. Okay, so baroreceptor is the first line management do by the system. It is around 70 to 150 mean arterial pressure. Maximum pressure at baroreceptor response is 180 mmHg around. If mean arterial pressure be below decrease 70, the chemoreflex is stimulated. It is a semi line of control. It is around 40-70 mm. Chemoreceptor direct parasympathetic decrease heart rate. Indirect effect क्या it is stimulate sympathy SNS increases the heart rate. Okay. The last response we have CNS ischemic response. It activates IRV-LM. It is a part of sympathetic nervous system, rostral ventrolateral medulla that increase BP up to 250 mm of Hg. It is the most powerful and it is also known as last resistance. Okay, because someone is dying and you have to give blood to all part of the body. So fluctuation in BP recording in the nervous control mechanism is by the two waves, Mayer waves and Tobe hearing waves. Just remember it by yourself. There are other reflexes. There is the based on heart rate changes. There are bradycardic reflex and the tachycardic reflex. We have mnemonic for the tachycardia. It is the VB. The V means wife, and wife increases heart rate always. So it is a tachycardic reflex known as brain bridge to BB. Okay, BB is the Urdu word for the wife. Okay, so it is the brain bridge reflex (BB). Brain bridge reflex in present in congestive cardiac failure patient. The edema and fluid overload lead to increase effect lead to right atrial stimulation. It stimulates SNO and increases heart rate. Okay, in the congestive cardiac failure patient. We have two other reflex. This is the bradycardic reflex, the basal jet reflex due to serotonin (PYQ) released by infected tissue seen in profound hypertension lead to profound hypertension and bradycardia. And Cushing reflex in a trauma patient with head injury, we have increased who have increased intracranial tension, the heart rate and bradycardia. Okay, both are same. Heart rate decreases, also bradycardia. Okay, so I think this chapter is finished. Thank you. I hope you have many of your concepts are clear.